today for this seminar celebrating the University of Waterloo's 50th anniversary. I'd like to welcome our webcast viewers, and as well, we'd welcome our Ontario Telehealth Network sites. By the way, this seminar is being recorded and is being broadcast over the web. We ask that you hold your questions to the end of this seminar presentation so that we can get a real mic or a virtual microphone to you. A warm welcome to our guest speaker, Dr. Brian Haynes from McMaster University. I'm not going to introduce Dr. Haynes right now because Dominic Covey will introduce our speaker in a few moments. A special thank you to our seminar series sponsors. They are McKesson Canada, Ontario Smart Systems for Health Agency, Borden Ladner Gervais, and Health Information Management and Communications Canada. I have a couple of quick announcements. We're holding 2 workshops on health privacy and eHealth Risk Opportunity Report Card in April. As well, we're holding another Health Informatics Boot Camp. It will return to Waterloo in June. There's more information at the back, and for those of you that are remote to this seminar, please send us a message if you'd like to have more information about any of these events. This is the 3rd seminar of the Smarter Health Seminars, celebrating our university's anniversary. The anniversary theme is Why Not? These seminars are dedicated to this theme and will explore different why not questions related to health informatics ideas and innovations. Following this presentation today, we continue with many great speakers. Next month, Mr. Tom Clausen is speaking. Future speakers include Dr. Jeff Fong, Dr. Octo Barnett, and Senator Michael Kirby. Our agenda today is as follows. Dominic will introduce our guest speaker. Brian will speak about 45 to 50 minutes. We ask that you hold your questions to the end so that we can get the mic to you. Please signal if you have a question, and I will run or Dominic will run and get the mic to you. And those on the web or teleconference, please signal that you've got a question. I'll now turn this over to Dominic, who will introduce our speaker.
Well, good afternoon and welcome. I'm glad you had the chance to come here today. I was just reminiscing with Brian when I first met him, and we finally converged on he was at Toronto General at the time, and was working with a fellow by the name of Sandy Logan, and was involved in hypertension management. So we're sharing some of our stories from the time and what our backgrounds were related to that. I've really heard about Brian a lot because the DME program at McMaster was one of the inventions, and he and Dave Sackett had a huge amount to do with its creation and its being carried through. Over the years, I became aware of work that Brian was doing, and if you want to read something very interesting, I don't he'll tell you the exact year, but Brian did a study of the whole bunch of systems that had been tested through various clinical trials related to computer interventions in care, and found some extremely interesting results. And that is that the hypothesis that we all had that these systems were very effective was not found in the work. And that type of analysis has proved to be hugely valuable, and I understand he's going to talk about that briefly. The formal part of this is Brian received his MD in 1971 from the University of Alberta, PhD in clinical epidemiology from McMaster in 1975. He joined the Faculty of Health Sciences at McMaster University in 1977, where he currently is Professor of Clinical Epidemiology and Medicine, Chair of the Department of Clinical Epidemiology and Biostatistics, and Chief of the Health Information Research Unit, and also on the active medical staff. Brian is a fellow of the American College of Medical Informatics, one of the early group that was recognized this way, and had an opportunity to meet with him a number of times at those meetings. I'm looking very much forward to this presentation. I think you'll find it informative, and I'm sure with his wry sense of humor, entertaining as well. Brian, welcome.
Well, thank you very much for that kind invitation, and also to the superb arrangements for meeting. Thanks Shirley Fenton in advance for her detailed description of how to get to the office down to the step. It was really remarkable. It's incredible. It's a pleasure to be here. I got my MD when I was about 14, which makes me the same age as the university. I'm going to talk about things, some of which have medical implications. If I use words that are unfamiliar to you, just sort of wave and I'll try to translate them, because this is about knowledge translation. And the word that I would like to emphasize most here is effective knowledge translation. This is just a little bit ahead of where we are right now. It's from a year ago. But we're sort of in I like metaphors, and it's sort of springtime for knowledge translation. We're not really edible yet, but there's lots of promise, and things are starting to pop, and I hope to share some of the things that are popping in our area. Why are the times so ripe for doing something about knowledge translation? Well, we're pumping about $100 billion a year into health research around the world. This has been going on for about 50 years of this order of magnitude. And a lot of new knowledge is being generated as a result of this, so that we actually know how certain diseases work and what treatments work and so on. We also have a lot better applied research methods. Dominic referred to the DM&E program, which is now the Health Research Methodology program. That was one of the first programs teaching graduate students how to do clinical trials and test properly innovations and interventions and so on. Those have advanced over the years, and we now get pretty good reads on whether treatments will work as their inventors hope they will when we apply them in practice. We have information technology to take the information, organize it, and put it at the point of care or anywhere that you might want to get it. We also have rising expectations from people about what they'll get from healthcare services and rising alarm about how much this is all costing. And this puts the work that we're doing into a crucible that's really quite incredible and intense to try to get it right. So what I'm going to talk about is where we are in trying to get it right, make sure that we get knowledge into action, get false information, which there's much more of than there is good information, out of practice and so on. Sir Muir Gray, who's quite a wonderful fellow, has given himself a position called Director of the National Knowledge Service for the UK. He actually wrote the job description for this, wrote it in an editorial in the BMJ, and shamed the government into creating the position, which he now occupies. And he declared knowledge as public enemy #1 of disease, and pointed out that the application of what we currently know, will have a bigger impact on health and disease than any single drug or technology. Now, Muir isn't particularly given to understatement, but I think this is a gross understatement. We now know a lot about disease and disease management and so on that's not being used. The bottleneck is so tight for this that if we were to open up that bottleneck, it would blow away what we could do with all the money that's being invested now in basic research to find new things. We really do have to solve the bottleneck problem with this, and if we do, it'll open up management of these conditions in a way that currently isn't being realized at all. There are many types of knowledge, and these are three forms that Muir Gray points out. Knowledge from research, sometimes called research evidence, knowledge from the analysis of routinely collected data. This is what ISIS does in Ontario and other groups do. Knowledge from the experience of providers and patients. And clearly all three forms of knowledge are things that we want to have, put them together, and we've got a pretty powerful mix for making progress. But what I'm going to talk about is just the knowledge from research. And I want to point out the fact that I recognize this is only part of the solution, yet it's the part of the solution that I think has the hugest potential for making a difference. A group of us at McMaster, Dave Sackett, Peter Tugwell, Gordon Guyatt, and myself, created the concepts of evidence-based medicine. Gordon Guyatt was the one who actually came up with this term. And this term has kind of caught on around the world as the link between research and practice, which is exactly what we were hoping for. Evidence-based medicine is an attempt to build bridges from research to practice, or put it more simply, to create research-enhanced healthcare, to do a better job of healthcare through using research. Unfortunately, there's some barriers to doing this. This is from, it's a bit stylized. It's from a project in Hamilton, Ontario, down the road from you, where we plotted knowledge of current best care for hypertension in practitioners against their years since graduation. As you can see, there's a slippery slope of declining clinical competence as people get further from the date of their graduation. And this is quite a reproducible phenomenon. The problem is not that people get senile, it's that practitioners tend to practice the way they learn. And as the amount of new knowledge accelerates, as soon as they get into practice, they don't get the same inputs and they don't pick up new things very well. So the gap between what they know and what they should know if they're going to give best care to patients continues to increase over time. This isn't an isolated phenomenon, as I mentioned. A study done recently, systematically reviewing all these areas, found that in 94% of studies there was a drop-off in competence with at least some tasks as physicians aged. This is a particular problem for generalists because generalists have a much larger knowledge base to try to keep up with. So primary care doctors, for example, much more than, say, a cardiologist or a left eye glaucomologist or something, who would have much narrower area. But we all have to be generalists these days because our aging population accumulates disease as they go along. And if you get in the hands of a cardiologist, but you have something with your GI tract, there's going to be a problem unless they've got some way to connect with knowledge base in the gastroenterology area. And yet, even for the most important advances, there is a huge drop-off or timeline for implementation. This is for thrombolysis, probably the most life-saving invention of the 20th century. So this is not current century, but it virtually stops about a quarter of people who have a heart attack who are going to die from it from dying. So it's very, very potent intervention. First known in 1975. A decade later, the textbooks are starting to pick this up. 5 years later, the textbooks are now on side, but only 40% of the patients are getting it. And then in 1993, this is already obsolete. It's not that we don't use thrombolysis anymore, but PCI, percutaneous coronary intervention, where they stick a catheter up and blast the clot out of the artery, is more effective, saves more lives than thrombolysis. Where are we with PCI? Well, in my community, it depends whether the ambulance turns left or right, whether I'll get PCI. Now, you're going to say, of course, PCI is very expensive. You need labs. You need to train cardiologists how to do it. They have to be available around the clock. There's like technicians there and so on. So it's understandable that this isn't being implemented. Well, what can you say about this one? This is warfarin for the prevention of stroke in people who had atrial fibrillation. Atrial fibrillation, 1 in 5 seniors over the age of 80 has atrial fibrillation. And that atrial fibrillation results in little clots forming in the heart, and then they go off to the brain and cause a stroke. And a stroke is a very devastating thing. It reduces your ability to take care of yourself, for example, if it doesn't kill you. Well, aspirin for atrial fibrillation not only doesn't cost us money, it saves us money. We save money. For every stroke averted, we save $25. Not a big deal, but at least what can you think of in life that does you benefit, that you actually pays you for the privilege of doing the benefit? Aspirin is actually even more cost-effective because it costs less, particularly to monitor in the follow-up for patients. It's not as effective as warfarin, but both of these are cost-effective interventions. They're win-win interventions. Well, what do you think the implementation rate is for this one? Any guesses on what proportion of people who have stroke receive or atrial fibrillation? 10%? Oh, wow, you really are pessimistic. About half of the people, there are some reasons why people shouldn't get this too, but about half the people who should be on anticoagulants for stroke prevention aren't getting it. Again, this has been surveyed over and over again. Hamilton, you may not know, is in fact the clot capital of the universe. And the atrial fibrillation stories on the arterial side of the circuit. On the venous side of the circuit, people get clots in their legs when they come into hospital, for example. And we can prevent that, again, by using warfarin or a number of other strategies that will reduce that down to quite a low proportion of patients. What proportion of patients get this preventive treatment when they come into medical wards in hospitals? Well, that's about 33% in Hamilton, and that is better than the rest of the universe. It's about 25% in Waterloo. Still, 33% is not very good, particularly in the home of clotology. Pulmonary embolism is the commonest preventable cause of death in hospitalized patients. So there's a huge incentive here to get this right. But in fact, we still haven't got it right, and we're going to have to do some work on that. A fellow named Stephen Wolfe, who's a health critic in the United States, a primary care doctor, wrote an op-ed in the Washington Post last year about this. Unhealthy medicine, all breakthrough, no follow-through. And I think that's exactly the way the situation is. We're spending enormous resources on developing new, better treatments, better diagnostic tests, and so on, and we're not following through and implementing those. Now, here's a spot to rest. Anybody know where this is? It's not, I guess, with the lighting here, particularly easy to tell. This is in Johnston Canyon and Banff National Park, and if you go there, you should go up Johnston Canyon. It's a wonderful walk up to the top of this. It's not really hard. Water, nice flowing down here. Good, clean water. Nice pools at the bottom. But of course, I did say that I like metaphors, and the metaphor in this particular case, imagine that you're actually watching this nice scene from here, and then you fall in. So you're at the bottom of the waterfall. Of course, the way that these things work, not only is the water cold, but that waterfall drags a lot of air into the water, so it becomes very hard to stay afloat if you're there. Well, that's just a little bit like what's happening with the research. We've got the researchers up the top here dishing out all this nice, clean, new knowledge, and decision makers are at the bottom of this trough, and it's coming down fast, and it's cold, and it's got the wobbles in it that make it hard to even float. So how on earth are people going to consume this in an orderly fashion and make the most use of it? They can't do it the way that the system works right now. To the rescue. Knowledge translation. The organization, retrieval, appraisal, refinement, dissemination, and uptake of knowledge, for example, important new knowledge from health research. And one of the reasons for the existence of the unit here is to try to turn useful knowledge into useful practice. I'm going to turn that waterfall on its side here, and we're going to take you through the steps related to knowledge translation. All of these steps begin with a bright idea, that light bulb that goes on in a scientist's head that says, here's something that might make a difference. And that gets tested. And the reason why this testing process of knowledge generation is wedge-shaped is because a lot of these ideas just don't hold water. So we knock them out. And that's what the scientific process is supposed to do, is to test and find out which ideas have enough in them to merit us paying much more attention to them. So the first step is knowledge generation. No single study has enough oomph in it to make justify a change in practice. We need to put all of the studies together to get enough information, because each study is a narrow slice of the truth, and we need to put a lot of these together. Well, we've developed high-powered ways of going about this. Cochrane collaboration just started in 1993, so this is not a long period of time. Started getting us to collaborate around the world to synthesize the knowledge, take all of the studies, be very systematic about them, treat them all fairly, and try to come up with a bottom line. Where are we with this intervention? Does it work or does it not work? How much does it work? Who's it work for, and so on. So that synthesis step is a very important one. But when we get the bottom line, we then have to do something called make a policy. The policy has to look at the evidence on the one hand, but then it also has to consider the local circumstances, the resources, the skill sets, and so on, to come up with what we should be doing here. Very important step. None of this works unless there is something going on at the local level or at the government level, trying to figure out where the resources are going to come from, and so on. So the policy step is really crucial to getting the evidence into practice. The next step is to try to figure out how to apply this. We can say that we want PCI. We can even provide the resources for PCI for people with heart attacks. But we have to actually build the facilities. We have to get the ambulances on site. We have to make sure that there's enough facilities and they're well enough run and they're expert enough to not do more harm than good. So the application step comes next. And then finally, we have to apply the knowledge at the individual level. And there we have a complex process where we have to take into account the patient's unique circumstances, and often they are unique, their wishes and the evidence. So evidence doesn't make decisions. It can be used in decisions, but it's not going to tell us what to do. We have to decide that in relation to the patient's own particular problems and what they want. Knowledge translation steps, then, are the ones sort of from the very end of this generation process right through the end of the decision-making process. And I'll tell you why we have a problem in these knowledge translation steps. This is the Medical Research Council and the type of research that it funds. This is before CIHR, primarily funding research at the bottom end of this big wedge, and not very much along the lines of knowledge translation. CIHR has done a better job of this and has moved this along, but this is a mighty thin slice of the research money that's available in Canada. It's going into the translation steps. So if there are problems at each of these steps, and I'm going to show you that there are problems, we're not putting much in the way of research funding into solving those problems. We're still spending more of the money, most of the money, at the discovery stage of knowledge and not in the translation steps. Let me show you some of the problems here. Go back to the first step here, generating research evidence. Unfortunately, too much of the research fails to address a real-world version of the problem. We contrive the research situation so we get a clean answer to the question we're asking, but we're often asking the wrong question, or not at the practice level that we need to. Now, we do have some ways of dealing with this. Large, simple trials have been pioneered by folks at Oxford and Saleem Yousuf in our area. These are trials where we are in real practice situations. We're treating the patients as they come through the door, not a selected number of them, and we're getting a minimal amount of data collection so we don't have to pay for the research overhead, but enough to know whether that treatment works or not. We also need a lot more head-to-head comparisons. These are comparisons of drug A, the new drug, with the current best treatment that's available for this condition, as opposed to a placebo where all we know if the new drug is different from placebo. Of course, if it isn't different from placebo, we're not going to use it at all. But it's easy to be better than placebos. We really need to know, is it better than the treatments we currently have available? And we're not getting enough of that type of information. In fact, in terms of the research wedge, can this work level of under ideal circumstances, much more of the action, and not very many of these does it work trials under usual circumstances. And as a result, what we have is a gap between the generation part and the synthesis part, where we have to extrapolate when we're trying to say, does this work in practice? Policymaker, here's something that you can use. It's even worse for devices and drugs, or services rather, where we don't have the regulation that requires even controlled trials. And some of that technology is really expensive, like PET scans and MRI scanners and so on, where we have to make decisions based on unsatisfactory evidence of usefulness. There are lots of comparators in these trials. Placebo is one that occurs a lot. Current best care, it would be a much better comparator, but usual care is probably the best standard for determining the value of new treatments. Usual care is what people get now. The one we want to test is best compared with that if we want to know what an incremental value would be under usual practice circumstances. But the relative frequency of studies, as I mentioned, is much favoring the placebo side of things, and we need to somehow reverse the testing so that we get more at usual care. Unfortunately, for regulatory requirements, all that's needed is to show that your new thing works better than a placebo. So the regulation is actually conducive to getting inadequate information about whether a thing works in usual care. Of interest, the cost is not wedge-shaped, it's sort of, I don't know, coffin-shaped or something, in that it costs money to test placebos. It costs actually quite a bit more to do it against current best care because you have to augment the care. It probably costs not much more to do it against usual care than it would against placebo. So surely we could get this right. We could shift the money over to or require people to test against usual care. Of course, the drug companies have argued it's actually unethical to test against usual care because it's not in their interest to do it and they don't want us to try to get them to do it there. Step 2, synthesizing the research evidence. Well, there's so much research to synthesize that if we try to do the usual industrial-grade Cochrane approach, which is to take every conceivable piece of information and scour the earth and get it all together and then synthesize it, I think we'll run out of steam, and I'll show you that in a moment. But I think what we need is some research into rating studies, abstracting studies, and synthesizing research. Why not use sampling methodology? We know about sampling methodology. We can get the same answer, or virtually the same answer, for a lot less if we take advantage of that sampling. Here's where we are with Cochrane. We asked the Cochrane folks to tell us how many reviews they thought we needed to be able to get up to date with the trials that are already available. And they said, well, we probably need about 10,000. Now, this goes up to 3,500 or something like that. And as of 2005, there were 2,500 completed reviews. So according to Cochrane, we were only a quarter of the way there in 2005. Of course, there's new trials coming out all the time, and that wasn't included in their figures. As it happens, though, Cochrane has stimulated other people to do systematic reviews, and more than half of all reviews published now are non-Cochrane reviews. So we do see some progress if we add those two together. We're up at perhaps halfway where we need to be in synthesizing the evidence. But this is an excellent example of what can happen with collaboration. A lot of the work done here is voluntary. It's done by people who are interested in finding what happens when we put the evidence together. It does feed into their own research agendas and so on. But this is a worldwide effort to try to catch up with the evidence. It's undervalued in academia, although that's starting to change. And it's underfunded, and hopefully that will start to change if we shift priorities to making sure that we're capitalizing on the evidence that's generated. Third step in this route, one of the problems is developing evidence-based clinical and health policy. In fact, most health policy is made by people who don't pay much attention to evidence at all because their priority is to get votes. And they're often much more concerned with resources than they are with evidence. And they want to know what people would like rather than what evidence has shown would actually benefit them. But we are seeing examples of collaboration in Canada recently. We have now a National Drug and Technology Assessment Program, CADIS, which used to be called CODA, the Canadian Agency for Drugs and Therapeutics in Health. And it does systematic reviews of evidence on new treatments that are then shared across the provinces. Before, it was every province for itself. A lot of provinces couldn't afford to put much into the research synthesis. This at least provides a collective effort towards getting to the bottom line of what the evidence has to say that then can be used at the local level, the provincial level, to make decisions about which drugs to bring in and pay for. I put a big question here about beside local leadership, but it's clear that the policy will be different in Waterloo than it will be in Hamilton for some types of interventions because of the resources here, the skill sets, and so on. And it will surely be different than it would be in, say, Collingwood, or name some small community in the north that you have to get to by plane. So we do need that local level, and that is a weak link, and I'm going to come back to that in a moment. But at least we are collaborating to try to get the evidence sorted out. Application step, poor access to current best evidence. There isn't a one-stop shop right now for current best evidence. But we are seeing a lot of progress in that direction. We do need to be able to get at a crystallization of the evidence on a disease-specific basis. This is one of the projects that we're doing now in which we are attempting to do that for patients with diabetes. There are about 50,000 diabetic patients in the Hamilton area. I work in the diabetes clinic there. We can see 5,000 patients per year. So that means if specialty care is needed for those patients to get their regimens right, they got to wait 10 years on average before they can be seen. Now, they don't have to wait that long, and most of them are actually cared for at the primary care level, but they're not cared for very well on average. Diabetes in Charge provides an opportunity for patients with diabetes to match their exact characteristics against the guidelines for their care, get that sent back to them as here are the things that you need to do or should be doing, and a copy can go to your doctor if you agree to that, and we hope you'll go to visit your doctor to talk about it. So at least we're providing an opportunity to find out, for people to find out what sorts of things they should be doing for their own health. Well, we don't have the results in quite yet. I'm going to tell you about a major project that we've been involved in for the past few years to try to develop a knowledge refinery that takes all of the world's new knowledge related to healthcare in a broad range of disciplines and conditions and tries to make that available to practitioners according to the sorts of things that they're doing. So we're going to use informatics techniques here and evidence-based techniques to match up the new knowledge as it comes out, top of that waterfall, but parcel it out in a manageable quantity to individual practitioners according to what relates to their practice environment. So those are the basic principles of what we're trying to do. It would seem to practitioners at the bottom of that waterfall that in fact there's way too much coming along. But as I'm going to show you, the amount of new knowledge that's relevant to the practice of an individual physician, if it's sorted properly, is very minuscule, very manageable. We started this a few years ago with evidence-based journals, secondary journals that go across a bunch of journals and pick out the studies that are ready for clinical attention. We have about 18 research staff who get involved in one step or another of this, go through 50,000 articles a year in 120 journals. That's a subset of about 500 journals where we've looked. We know that there's not much useful evidence in the rest of medical journals around the world. We apply critical appraisal filters. These are explicit, they're reproducible. We could teach you how to do this, but there's no need for you to do it because we're already doing it for these articles. And that shrinks the 50,000 articles that are published in these journals down to about 2,500 per year, or a 95% noise reduction. Now, of course, 2,500 articles is still too much for practitioners to read. Nobody could consume that. It's a couple hundred articles per month. So the next phase of this, which is the McMaster Plus project, is to take that 2,500 articles and develop a clinical relevancy filter. We did this by recruiting practicing physicians from around the world. We have about 3,000 of them. And when we get a new article that meets our criteria, we decide which disciplines might be interested in it, send it to 4 people in each of those disciplines, get them to vote on the relevance for practice and whether this is interesting, it's new information or not. And then on the user end, people sign up according to their interest, and they get the articles that their peers have looked at and said, this is relevant to your practice. That's what we're trying to do, is to sort out that waterfall into micro streams and feed it to the right people. So at the top level of relevance and interest, this comes down to about 20 articles a year for a physician in most clinical disciplines that are really must-read articles. And these are usually in clumps of about 3 or 4 around the same topic area. So you can't say anymore that you're going to drown with new information. Now, of course, whether people will buy this and take it up is something that we're involved in trying to determine, and I'll show you one of the studies on that. More importantly, perhaps, we can also feed the authors of evidence-based textbooks and alert them to the articles that they need to incorporate into their next update for publication. We've set a standard through evidence-based medicine that publishers now recognize at the sales stand, because practitioners ask them, is it evidence-based? For it to be evidence-based, it's got to be updated. It's got to pay attention to evidence according to the quality of that evidence and the relevance of that evidence. And there has to be an audit trail that shows that they did, in fact, pick up the new things. We're seeing publishers now ask how can we become evidence-based, and we can feed their authors with the stuff that relates to their specific topic. They don't have to get a librarian to do an intense literature search, very expensive process. They have to mine the world's literature. We've already accumulated the part that's related to clinical practice. Now that is another example of where collaboration can help. We don't pay a penny to the people who do these ratings. The reason we don't have to pay them a penny is because we're sending them articles hot off the press that are relevant to their practices. They get to see how other doctors are rating the same articles. They get CME credits for the time that they put in, and we time exactly what amount of time they do spend because they're doing this all online, so we can observe what they do. So this is something that results in us getting more people asking to join this service than we actually need to rate the articles. Of course, we keep track of performance and we read the people who are slow and so on because we want to get this done quickly. This is an example of an alert occupational asthma after cessation of exposure prognosis study that would come to somebody who is in internal medicine and the relevance and newsworthiness. I get this as an email. I can decide whether or not I want to follow it up. But I'll get alerted to new articles in that area when they come along. This is the trial which we did in Northern Ontario. The funding for the McMaster Plaster Knowledge Refinery part was provided by the provincial government as a build-up to support services infrastructure for Northern Ontario, the doctors who work there. In the baseline phase, they all had access to a digital library similar to what you would have in any academic institution. They had access to Ovid, and they had access to StatRep, which is a collection of textbooks of medicine. The two groups tracked the same amount of time spent looking at these in the build-up period, and then in the baseline period. And then in the trial period, one group, the group that's in blue here, received alerts from our refinery service and access to the accumulated alerts. And our objective was to see whether we could increase the use of evidence-based information. And as you can see, during this 15-month period, the full-service group used the information a lot more frequently than the control group, who just had access. And then we had to the digital library, and then we crossed over the comparison group, and it went up to the same level. So this is a sustainable increase in attention. Whether it results in changes in practice, of course, is a much more complicated question to answer. But at least it wasn't a sort of, we used it for a bit and then the novelty wore off. It seemed to be a sustained effect. This became BMJ Updates. The BMJ Publishing Group was kind enough to sponsor this on a continuing basis, and this is available free to practitioners around the world. And you can use it too if you want. So just to review here, take a bunch of journals, do the appraisal, send it out to clinical disciplines. This is the rating system. As soon as we have 3 or more ratings for articles, we start to feed into PLUS, which feeds BMJ Updates, and also feeds into 3 evidence-based journals, into PEER, which is the textbook of medicine by the American College of Physicians, into Clinical Evidence, which is the equivalent in the UK, and into Medscape Best of Evidence Alerts. So we're now feeding into a number of ways that we can get stuff to people. We want to, in my wildest dreams, infuse all of the things that say they're evidence-based. There's no need for them to have their own infrastructure to do this. It would cost a hideous amount for them to do it. It's cheap the way that we've done it. We've made it really close to less than a half-time person working for those organizations to try to make sure that the information that's going into information resources is a clear reflection of advances in knowledge that are important to practice. And in fact, what we've seen over the past decade is a huge maturation in the information services, at least, that are available. We began, obviously, with the original studies. That is the essence of evidence-based medicine. Then we saw the syntheses, the Cochrane reviews and so on, form the synopses, which are in those evidence-based publications. And now we're seeing the summary publications where that's assembled in textbook form so that when people look it up, they can see what's the current best evidence for management of patients. And what we're hoping to see down the road a little bit, and in fact this is already happening now, is to put this into computerized decision support systems that attach the knowledge to the individual patient's characteristics. so that the subset of knowledge that relates to their condition is instantly available when the practitioner is dealing with their medical records. Now, of course, that is the nirvana and the holy grail of informatics, and it's been the holy grail for quite a long time, and we're still searching for exactly how to do that. And I'll show you one of the barriers that we're up against here, and that's the preferences of practitioners for how they would keep themselves up to date. These are the ways on the left-hand side will come along showing you what doctors say they do to try to keep up to date. And on the right-hand side, I'll show you what studies have shown actually works. And I want you to notice the similarity or differences between these two sides. So doctors say, number one, they use journals to read. And of course, that's a hopeless task. I've just shown you that there's way too much information in journals, and they would have to appraise the quality and everything else. It doesn't work. Audit and feedback, though, does work, as where we look at the person's practice, we compare what they're doing against standards or against their colleagues and provide them with some information about this. Doctors say they go to scientific sessions. Nobody's ever shown that going to scientific sessions has made any difference in the practice of medicine. Somebody's actually tried to test them to show it didn't work. Patient-mediated interventions do work. The Diabetes in Charge project, where we send information to patients about what should be taken care of in their condition, that's one way to put pressure on the doctors to get with it, and that has been shown in trials to work. The problem is that there's way too much information for patients, so the same problem exists there. They're getting a lot of bad advice, and it's very difficult for patients to discern what the good advice is. And so they're as likely to go into a direction that will line somebody else's pocket but not help them as they are to get any advice that's useful. Informal consults, doctors talk to each other in the hallway, and they like that as a way to keep up to date, but it's very difficult to study that. Preceptorships, though, do work, whereas a formal period of training, so doctors would have to go back for, say, a week, a year, where somebody would look over their shoulder as they caught up with new techniques for management of patients. Quite expensive. Doctors like to go to rounds. There actually have been studies of rounds that have shown that they impart no useful knowledge. Sorry. Maybe they're important for other reasons. I hope so. Educational influentials work. These are where you feed evidence-based information to practitioners who are identified by their colleagues as somebody they pay attention to. That's one of the sociological phenomena in practice. People look to the influential docs for whether they should be doing something. Medical school events don't work. Academic detailers do. This is where is taking a leaf out of the pharmaceutical detailer's handbook and sending somebody from an academic institution out to a practice to provide samples for new products that are known to be effective. And then finally, doctors say they go to the library. I never see them there. Of course, I never go to the library myself. Who needs to go anymore? Computerized decision support systems, though, have been shown to have some effect, and I'll show you the results for that. So a complete mismatch between doctors' natural tendencies for keeping up to date and what we've shown to work. One of the problems is that the continuing education system, at least in Canada, is totally toothless. And here are some of the things I think we need to change. We need to make recertification, or what's being called revalidation now in Canada. That's from the UK. We have to get that in place. The people, it's like the Ontario Gaming Commission regulating itself. It doesn't work. It really has to be taken out of the hands of health professionals. There need to be some standards for doing it. We need evidence-based standards for medical information. A lot of people are consuming the wrong information that often is from people with vested interest trying to sell them things or sell their patients things. We need to shift continuing education funds from didactic sessions to formats that have been shown to have more impact on learning. Audit and performance and feedback is important. And electronic medical records with the decision support embedded in them. Those are some of the reasons. Application step, clearly we do have information overload, and this is where computerized decision support might help. And so what I'm going to show you is the current version of that review that Dominic referred to. Are computerized decision support systems effective? I'll summarize this very quickly. 100 studies in this review. It's a systematic review, and we found 100 randomized trials testing computerized decision support. In 97 of these studies, 63 showed an effect on practitioner performance. That is, did the doctor do what guidelines suggest they should do? More frequently that happened, and it happened most often in reminder systems. For example, a patient comes in with a sore thumb and the reminder says, oh, by the way, they haven't had their tetanus shot in 10 years, better get that done. Well, that is a fairly effective way to use computers in practice settings. In disease management systems, again, a fairly high success rate. Drug dosing and prescribing systems, also reasonably good. Diagnostic systems, not very useful. Now, that's just the practitioner performance. So what we really want to know is the patient any better off as a result? Only half of the studies, 52 of the studies, even looked at this, and only 13% of them showed there was a benefit in terms of patient outcomes. Now, there are some methodologic reasons for this. It's expensive to do the studies where you would have patient outcomes. You need more patients in them and so on. And a lot of these studies were just too small to show an important difference, even if it was there. So I don't want to leave the impression that they don't work. They haven't been properly tested for this. None were improved, though, and I have to say this, none proven to improve definitive outcomes, major outcomes. Most of the studies that looked at outcomes will look at whether the blood pressure is a bit lower, whether the blood sugar is a bit lower. They don't look at whether people prevent complications of diabetes or hypertension. Again, those are expensive studies to do. But at some point, health informaticists have to come to grips with the fact that if they're going to be taken seriously as part of the solution to these problems, they're going to have to test their interventions in clinical trials the same way that we do and require for drugs. I'm not going to go into the details of those. So we're back at our knowledge translation thing. Another part of the solution here is to shift money from basic science research over into applied research. If we can get CIHR and other funding bodies to say, okay, we recognize that what you're doing is research, and we're prepared to be fair in the allocation of research funds, then perhaps we can conquer some of these steps that so far are being resistant to effective knowledge translation. Now that requires a major shift in thinking and overcoming the inertia and the vested interests of basic science, which will go totally against us making this shift. And it won't matter whether they realize it's good or the right thing to do. It all has to do about turf. So there's a major battle, but CIHR has undergone a major transformation in the last few years and has shifted some money into this area. And they do have a knowledge translation receptor site at CIHR now, which they never had in the past. So there's been progress. On the other hand, they've been cut back in their funding, and they're not going to get anywhere with the Conservative government right now for funding. So again, I'll go back to turfism, I'm sure. And I really want to emphasize what has to happen if this is going to happen in your community, and that is there has to be a stronger infrastructure for local decision-making related to implementation of best practices. A lot of local leadership is consumed in the personnel issues of Dr. X is drinking too much, and we need a cardiologist, and so on, and fighting with hospital administrations. This is where collaboration really could pay off. If hospital administrators and the service professionals who are taking on the roles as service leaders and so on could finally realize they're supposed to be on the same side and that they actually need to make decisions supporting one another. Okay, so final chance to convince you that there's things that need to be done. I think these things could make a difference. The information systems that we're working on and developing computerized decision support systems that are kept up to date. I think the refinery we've developed makes it feasible for computerized decision support to be kept up to date. Traditionally, what's happened is that people who develop computerized decision support spend all of their effort developing the system, and not paying enough attention to the fact that the knowledge base is changing, and they need to make a system that can accommodate new knowledge on an unpredictable and often fairly quick basis. So we need to get together with the CDSS folks and get the evidence components right. And that's just actually happening at the hospital level. There are companies like Zincs, for example, in the States that have got an evidence-based infrastructure that they provide to hospitals for updating their systems, but there's not a vital link at the patient level, which there needs to be. We need continuing education with teeth. We need to strengthen local leadership roles. We need to partner best practices research with hospital and health system quality improvement efforts. And we need to shift some dough into the research side of this, or we will be working with relatively weak methods of providing changes in knowledge translation. So that's my agenda, and I'm going to clone myself and go for another few decades to get it all done before I quit. And you don't have to quit anymore in Ontario. I did want to point out that I think one way we could get this geared up is to look at win-win evidence. There's a small subset of research evidence that not only results in improved outcomes, but it does so at reduced cost. There's a reasonable number of these. If we could look at those and say, okay, let's take this through all those steps and try to get everybody on side for it, to get the wheels greased for the more difficult, the stuff that works but costs a bit more, where you have to make resource allocation decisions. If we could do that, then I think maybe we would get the system tuned up for an evidence-based era where we could actually make a big difference in terms of patient outcomes. And there's Bambi to say hello. Thank you. That's all I have to say.
Thank you, Brian. What I'd like to do is to give each of you a chance to make a comment or ask questions, and just ask to put your hand up as early as you can, and we'll get a microphone to you.
Thank you so much. I very much enjoyed your presentation. One of the frustrations that we feel in the work that we do with personal support workers and people who have very little education, unlike physicians who tend to have a little bit more education and know how to use the internet and even own a computer, is how do you get that knowledge translation to those groups of people in terms of both translating it into accessible language that they can understand and showing them how to put things into practice. Have you got any thoughts about that?
I have some fairly extreme thoughts about it. I'm in that sandwich phase of my life where I've got elderly relatives who are being sustained in the community or not very well in the community and in hospital right now, in fact. Partly because personal support workers don't provide the kinds of things that need to be provided to keep them out of hospital and keep them healthy. I guess there's two parts to this. One is the resources that are put into support services for community are minimalist, and they're in competition with the bigger hospitals which have the fancy PCI units and so on. So there's a resource issue here for not being so minimalist about the presence of those workers. The second is we do need a training system for those workers with a set of standards. And as far as I can tell, there's a reason why those people have minimal education, and there's a reason why they don't get training, and that's because the whole effort of the government is to keep the costs as low as humanly possible. So you really have to go up to policy level and convince the government that they're losing out on this, that they're actually making it the whole system cost more. It's a matter of pockets here. It's going to cost more not to have that personal care worker get the person up, make sure that their quads are strong, that they're getting adequate nutrition, that they're actually eating the meals which are provided to them, and so on. those things are pretty basic. I don't think they make a high IQ. And often the people who are doing these jobs are not unintelligent. They're often immigrants who can only get that kind of work. I think there's a great potential there if we focus on the things that would make a difference for improving the health of the people that they're caring for at home or providing support for in the hospital. The problem in the hospital, of course, is they put a person in a bed and then their muscles melt, and nobody realized. There's a study that has shown that it's win-win, cost-effective to get people out of bed in hospital and keep their muscle tone up. That you can shorten the hospital stay, increase the likelihood that they'll be able to go back home, as opposed to having to go to an institution where somebody else is going to watch them in bed. But we don't do it. You can't get that kind of care on the ward service. Sorry, that's a very long-winded answer, and it comes from recent Greece.
Brian, you mentioned toward the end the issue of keeping evidence up to date. I mean, you may produce evidence, but somehow getting it into actual use must be the biggest single problem in an institution. There's no one whose job it is, except maybe in larger institutions, the librarian perhaps, to get the evidence into actual use, either through systems or through other techniques. I mean, what's the answer in the community hospital to this?
The organization of clinical services in hospitals, there's always a service chief whose responsibility is quality of care, but who often gets bogged down in bureaucratic sitting in meetings where, well, I won't go there, but there is an infrastructure, but that infrastructure is not being used well to bring in new procedures and new ways of doing things. It could be organized. For example, the rounds that most institutions have and that are part of what you have to record in order to keep up your license and so on, those rounds could actually be changed into, okay, let's examine what we're doing in this area, and here's the latest review that shows what we should be doing. Let's take a look at this and see what we can be doing on the local level to do it. What they usually are is somebody coming in, sponsored by a drug company, and talking about the latest drug. Hardly the way to make a decision about what we should be doing in practice. So I think we could use existing resources. In fact, I often wonder if we just reorganize the way we use the resources we have, we could be doing a whole lot better. We don't need to inject new resources in. We actually need to shift the resources from one way of doing things to another way of doing things, and that would make a huge difference.
You could use maybe the medical records types, the health information managers, as one of those kinds of people. But that's getting the evidence, if you want, into people's hands. How do you get it into their actual practice? I'm thinking of how do you get it into the systems themselves?
Yeah.
If you look at different systems that are there, and I mean, what are the issues in getting that knowledge into a form that it can be loaded into a McKesson system and a Meditech system and a who knows what else system, and actually begin to influence the way in which people make orders or carry out their work?
Well, that's where standards come in. What can go into those systems has to be in some way set against a standard for what they have to deliver. And if there's money involved, then you can set standards. If you just have everybody from their own budget trying to figure out how they're going to get a record system and no rules or regulations for how what criteria they have to meet, then you get the current sort of chaos that exists. There are standards for hospital record systems, and they need to be constantly modified and upgraded and include the components of things that would change practice as well. But so that's what I would do. I would say, listen, these are going to keep people up to date in the practice that they deliver. We're going to have them set up and meet a certain standard to do that. That's not in place at the present time.
So you need to improve the procurement process in order to do that.
Sure.
And also, I would presume you need to provide the evidence in a form that can be of a standard. I'm thinking of standard languages that can be loaded into those systems.
For sure.
Over there.
Brian, this is a wonderful talk, but it's very depressing because all that work that people do in the basic research funnels down to a very, very tiny point, and then the uptake is not very high. So as your work has shown, I mean, there are methods to make it more systematic and so on. Have you given any thought, or do you know of any work that does the same for example, in primary prevention? Where there isn't, there aren't all these clinical trials of that. There are just, let's say, stop smoking, services and so on.
Well, in fact, there's quite a lot of research related to stopping smoking, both at the behavioral intervention level and also drugs for doing that and programs for doing it.
Is that part of your?
Yes, absolutely. Yep. We review all of that evidence. All of the preventive procedures are included in what we take a look at: screening procedures, vaccinations, immunizations. For example, there's good trials that show that in institutions like elderly care institutions, it saves lives to immunize the staff for influenza. It doesn't change much if you do the influenza vaccinations for the patients. Now that's something that should be incorporated in policy, and all of the institutions should be vaccinating their staff. That's been known for quite a while, but it's not uniformly done, and it's often resisted by unions, for example. How you'd handle a policy issue, I'm not quite sure, but we do prevention. That's part of what we cover.
Oh, that's good. Actually, your point about the unions brings up a really interesting sort of structural problem that you face, that there sometimes you know what to do, but there are some either political or organizational structural blockages. So even if there are individual clinicians that want to do it, they're prevented from doing so because of something about the system.
Well, not even the unions would prevent people from getting vaccinated, but often people use their unions to prevent themselves from getting vaccinated. I think that, one of the themes that, if you look at the success part of what I've told you about, it's come through collaboration, and I think it's collaboration building that would have a major effect on this, where we actually try to identify the common ground for the various groups that are involved in it and figure out how to get those things that we all agree on done.
On? Yeah. It was an excellent presentation. This is more of a higher level health policy question, and I can see that the applicability of the way in which you've developed this certainly can apply not only to frontline medicine, but also to health policy and translating that into policy changes. And in Ontario, with the local health integration networks currently available in the integrated health service plans, which identify the local health needs based on consumer input, and the ability to change local health coordination, planning, funding, that this is an ideal opportunity for the knowledge translation and the whole health, e-health initiatives that are happening across the local health integration network. So my question to you is, have you considered of using this model to have discussions with the provincial government, Ministry of Health, or even local health integration networks with the e-health strategy to look at how can this be used to translate into health policy changes?
Yeah, my area has been involved directly with practitioners, but John Lavis and my group, my department, is specifically trying to figure out ways to involve or to harness evidence in digestible packages for policymakers, because they need different types of inputs. The evidence is part of it, but they need it in a certain fashion, a certain timeliness, and so on to fill into the processes that they have. So we are working on that. The UK is probably the most advanced area for doing that kind of integration, and they've developed various models for trying to have groups deal with the purchasing aspects of health services and then provide them with inputs like NICE, which is the National Institute for Clinical Effectiveness, where they do systematic reviews, and they actually have a government mandate that says if NICE recommends it, the government has to find the resources for it within 3 months. So there they've hardwired the evidence into policy for health practice. I hope that, I don't know enough about the track record of that process to say whether we can transplant that here, but that would be something that the LINs should take a look at to see if they can adopt some of that process. We do have the same evidence that NICE has. In fact, we have all the NICE reports, so we don't have to produce it ourselves. We've got CODA reports and so on. I think the LINs, if they focused on the evidence side of this, could make some strategic decisions that wouldn't have an important influence over the way that healthcare is delivered in their area. They're just starting up, and I think they've got a really difficult task of trying to figure out, you know, what's our mandate, how far can we go, what resources do we have to do it. But I think that's a potentially vital link between evidence and practice.
This is something that occurred to me. It's not studying the final practitioner endpoint that everybody seems to be interested in is very important. But what struck me would be interesting to study is textbooks, because they're public. And what gets, does the information you're feeding to textbook authors actually get in?
Right.
And is it accurate? If it does get in, is it a mere citation, or so you could assess transfer of knowledge to textbooks, assess its accuracy. If there are two specialties, I don't even know what the kind of medical textbook, the general ones or the ones for different specialties. It would be interesting if the same presenting problem gets handled by different specialties. Do they present different kind of information, and is there sort of bias and so forth and so on? So kind of that, because that's the public record, and presumably this is what medical students are reading, and your very first graph suggests that medical students are more on top of things than people as they get older. So that was
right.
A free association I am.
Importantly, much of what's written in textbooks about at least the evidence side of things is wrong. And what we try to do is to set a standard that publications will have to come up to. That is an evidence-based standard that has an auditable trail between declarative statements in the textbook about what you should do to the evidence that supports that, and then feed the authors of the chapters with the current best evidence and hope that that gets translated into an accurate statement. Now, we're in a relatively early stage of that, but I showed you, first of all, that textbooks are out of date. On the thrombolysis example, it took them 15 years to get it right. Second, two of the publications that I showed you that we're feeding into now here in the United States and clinical evidence in the UK were rated at the very top by a library group in the United States, part of the Medical Library Association, as being examples of where they thought textbooks should be. We had no influence on them in doing that. Somebody sent me the information from them. So the standard's starting to be recognized, and we now have major textbook publishers coming to us and say, how can we get evidence-based? What do we have to do for that? And we're starting to feed some of those. Harrison's, which is the most widely circulated textbook of medicine in the United States, that company has said we've got to do something because the evidence-based guys are taking customers away. So they're now contracting with us to feed their authors. Whether this will come out in the end with this getting exactly the right message, I guess, is something we'll discover down the road. But at least if it's auditable, people can challenge them and say, well, you didn't get it right. If it's not auditable, which it isn't right now in Harrison's textbook, because they just put a couple of references down the end and you have to figure out what relates to the content, there's no way to challenge them on it unless you come up with the references yourself. So I hope it gets there.
Oh, okay. I'm doing my master's thesis on the material on SSRI websites, and I'm quite struck as I'm going through the material by the contradiction between what GlaxoSmithKline and Eli Lilly, these companies, are saying about something like side effects, and if you Google any of these medications, what's out there. And I'm just wondering, you were mentioning the importance in clinical decision-making of individual circumstances and wishes and all of that, and I'm just wondering how physicians in their clinical practices are able to reconcile contradictions like that between what patients are experiencing and the literature from the pharmaceutical companies and the journals and all of that. I'm just wondering how that process is carried out.
Not very well. And I don't know what the solution is to that. The internet is making things worse as far as I can tell, because there are no standards required of information. In fact, its whole ethos is to promote freedom of expression. And as a result, in this particular application, what you get is a lot of false advice about the information and no curb on that, particularly in internet land, because you can send it out from the Maldives or someplace that doesn't have any regulations, and it goes everywhere around the world. So I think that is a big problem. The only thing I can think of that could help that is that you have to set a standard and you have to provide people with access to sites where you can get bias-free information about things like SSRIs and adverse effects from them. Cochrane tries to do that. It has a consumer component to it where they translate the most patient-important systematic reviews from the Cochrane collaboration into lay language and make that accessible to people. So the best I can do is say, look for sites which state the basis on which they make their claims and have no obvious financial interest in anything other than the truth.
Thank you very much, Dr. Haynes. It was quite an interesting presentation. And I'm assuming copies of the presentation will be available on the website? Okay, great. One of my questions was with regard to your slides. You mentioned that local leadership is engaging local leadership, I guess, as part of the solution. And I'm assuming you're talking about clinical leadership. What I'm wondering is, what are some of the methods that you've come across that have been successful in achieving that?
Well, I'll tell you what we're trying to do, and then I'll tell you a little bit what I know of other jurisdictions. What we've proposed to our hospital is to develop a best practices research institute that will work alongside with the quality improvement team in the hospital. Most quality improvement teams exist to satisfy accreditation requirements, and frequently those have nothing to do with best practices except for the obvious of making sure that the bedpans are cleaned and so on. I don't want to denigrate that, that's very important to do, but they're not aligned towards best practices. But if you put them in conjunction with best practices team, maybe we can get these things aligned and get the service chiefs also engaged in that. In the States, which is at the extremes of how you don't do it and probably the extremes of how you do it, there are certainly organizations like Kaiser Permanente and the VA Hospital Group where they have good information on what their practices are. They have good people working in the area of summarizing evidence and integrating evidence into practice, and they have trials showing that they've made a difference. I think that kind of managerial approach where you can line up the objectives of the institution according to quality of care priorities can work, and they've shown it can work, and they've shown magnificent effects. Examples in Canada of that, cancer care is organized in the province according to a network, and that network sponsors a review group that happens to be in my institution, my department, that works with each of the local sites, and they have local leaders for the different diseases that are important. So they commission the reviews, they work with the reviewers, They put the reviewer, once the review is out, they then engage in how we're going to deal with this information and how we're going to change the system. And it is a system so that they can spread the information across all sites. It's not every site for itself. And I think that kind of networking really does pay off, and that's what we should be aiming for. We're too much working in isolation without the resources to make this happen.
Thank you for this presentation on a fascinating subject, because we live in a healthcare system which is resource constrained. So anything we can do to use the resources we have can have a significant impact on the patient. And using guidelines to make sure that the patient is sent to the right diagnostic test or get the right intervention first really makes a difference. I've read somewhere that it takes 17 years between the time evidence has been found and the time it's actually used in clinical practice. And one may hope that with the internet and with computerized based system, this type of timing could decrease. I was also interested in understanding what your position was with respect to involving the patient into receiving such translated information, because you see sometimes a patient who maybe almost knows a bit more than his own doctor because he's researched his own conditions so extensively, and the doctor has to be informed about so many things. So do you think that can have an impact?
That's not my area of expertise, but there are good people in Canada working in terms of patient decision aids, for example, and testing those decision aids. Tim Whalen in our group at McMaster is working on this for breast cancer patients, for example. The research for patient decision aids shows that it can increase the satisfaction of patients that they've received information that's of value, but doesn't necessarily increase the satisfaction with their overall care. And nobody has been able to show at this point that it makes a difference in terms of patient outcomes. I showed you the Diabetes in Charge project that we had, or told you about it at least. That one is directed at patients so that they can get access to the information, out of all the information on diabetes, the information that relates to their own particular situation, so that they can see what the guidelines are for them. We'll be analyzing the results of that in a while, and hopefully we'll show that that does have some influence on the success of those patients in getting guideline-directed care. So I think that's very important. I think that the problem is underestimated, though, of communicating with patients. And I guess we've still got a minute. One of my colleagues, Alex Haddad, involves patients with cancer in the development of patient-oriented guidelines. In that investigation, he had them tell him what they needed to have in their guidelines. And it was often quite different from what the practitioners wanted to have in their guidelines. For example, patients were much more concerned about side effects of drugs, and they wanted to know what those would be and what they could do to cope with them. And he got them then eventually to sign off on a patient-oriented guideline that they said was what exactly they needed to know. And then he tested to find out if they understood it, and they didn't. I don't think we know very well how to communicate. There's obviously some very bright people, smarter than doctors, who can understand the information related to their own disease condition. But there are a lot of people who are at a literacy level that's too low for us to communicate using simple language. It just doesn't pass. So I think that that's a very important area, and I hope you will tell us the answer. Yes, good. I'll be watching.
Just wanted to remind people who are online that they can ask questions through the chat facility, and if anybody has questions, and the audience, be sure to let us know. We had an interesting discussion beforehand about the work that you're doing with McMaster Plus. I believe that's correct. Can you give us the website for that? And secondly, can you talk about the criteria that you use in judging literature?
Okay, so the website is hiru.mcmaster.ca. And on that website, you'll see a header that says projects, and you can then go right in and see exactly what we're doing in the McMaster Plus project. It was also written up in JAMA in 2006, and in JAMIA, where we published the trial that I showed you in 2006. And I can provide the references if you want, but they're on that website. The criteria that we use are based on principles of critical appraisal of the medical literature that we started teaching in the late 1970s. Gay Sackett was the person who started this off. They were published in a series of articles in the CMAJ, and then they went in a big series of articles in the Journal of the American Medical Association. They're published in context or by linked to all of our publications, so they're there. But I'll give you just an example. For a study of a treatment, we would only pay attention to evidence from randomized trials that had patient-important outcomes and at least 80% follow-up. So that's the kind of standard. Now, any standard that you have will have some false positives and false negatives, and we have downstream steps to detect the false positive studies that, even though they meet those criteria, aren't they're fatally flawed in some way. We may miss studies that have important information that don't make that standard. So we're trying to be pragmatic about this and skim the best evidence. And we figure if people take care of the best evidence and they've got time left over, then we'll get into the evidence at a lower level where a condition doesn't have really good evidence. But we're concerned right now that the really important information isn't getting through. So that's obviously a utilitarian strategy. We have criteria for diagnostic tests, for etiology or causation of disease, for prognosis, for quality improvement, and for economics of care. And those are all available on our website.
Interesting. What was interesting in that discussion was that this represents also an opportunity for journals, if they adopt your standards, for improving the content. I was kind of interested in sort of some average numbers you gave on the number of articles that meet the standards per journal, which is quite surprising.
But that's exactly why they won't do it. Because there's only one, on even the best journals, one article every 2 issues that makes the standard. So if they had a section set out for those articles, it would be empty most issues. I proposed this to journal editors when Ned Huth of Annals of Internal Medicine resigned, or retired, one of his retirements. And the editor of the New England Journal of Medicine leapt up at the end of my presentation and said that would ruin all the journals, because it would show how little of the information in those journals is actually ready for clinical consumption, and all their advertising revenues are based on advertising to clinicians. So the last thing they want to do is reveal that they've got such a thin patina of real evidence.
Yeah, interesting. Jeff Drazen, no doubt.
No, that was Bud Relman at the time.
Oh, okay, at the time. Okay, that's interesting, because there's a lot of interest in increasing the quality of the journals, which concerned people when there was the battle with the CMAJ. Mm-hmm. But that statistic that there's 1 article per 2 journals is really kind of scary when you look at the amount of material being published. So. Yes.
Well, the bigger view is that 90% of the information in journals is scientist-to-scientist chatter. And it's important to the advance of science for scientists to publish their results and other people to say, oh, phooey, I don't think that actually works. So that's important to science. The problem is it's packaged for clinicians because advertisers don't want to advertise the scientists, they want to advertise the clinicians. And that's where the system falls down. It promulgates the diarrhea of science onto practitioners. It really is going too far.
Any final questions from anyone here or in our virtual audience? Okay. Well, Brian, thank you very much. Really appreciate your talk.
Thank you.
And I want to thank Brian for coming today. I've enjoyed this talk tremendously. It was excellent. It was very well done. I know our audience enjoyed it as well. And so here's a not small token of our appreciation, a huge token. Anyway, I hope you enjoy that. And I hope you will all come back for our next seminar. It will be on April 25th by Mr. Tom Clausen. For those of you in our local environment, Tom has been very involved with looking at our emergency health care system at the hospitals. So we are delighted that he will come and speak on why not create the ideal health system through health informatics. So I know it will be provocative, and he'll be an excellent speaker. So see you next month.